Good morning to you all. Today we're going to go through the lesson Skin on Fire, Tackling Severe Cutaneous Adverse Reactions, Scars. First of all, I would like to go through the evolution of the concept of hypersensitivity, which started in 1951 with the concept of the tuberculin reaction, and then switched to the 1963 definition by Gell and Coombs, in which they refer to hypersensitivity as an undesirable, uncomfortable, or damaging response that arises from an overreaction of the adaptive immune system response. So, with this, we would include allergy in this definition, but also autoimmunity, and they distinguish 4 types of hypersensitivity based on the mechanism. Later on, 1990s, Pichler subcategorized these hypersensitivity type 4 reactions based on the cells that were involved and also cytokines and different mediators. In 2001, the ACI refined or fine-tuned the nomenclature for allergy and hypersensitivity with IG-mediated and non-IG-mediated or non-allergic reactions. And in 2017, the practical document from the IACI and the American Academy of Allergy and Clinical Immunology referred to the need of precision medicine, in which they mentioned that we had to define more on phenotypes and endotypes for allergy and hypersensitivity. And the last nomenclature for hypersensitivity and classification and describing mechanisms is from the IACI, the European Academy of Allergy and Clinical Immunology. It's dated by September 2023. And in here we have the different a broader concept for hypersensitivity because it refers to an undesirable, uncomfortable, or damaging response that arises from a tissue cell dysfunction or immune system overreaction. So in here we would include innate immune system, adaptive immune system, and also tissue-driven mechanisms. So this is like a far larger evolution from the very early classification of Gell and Coombs that was only on adaptive immune system. In here, you can see that allergy, hypersensitivity reactions include both autoimmunity and allergy. And for allergy, we have inflammation, immune system-driven reactions. We have tissue-driven mechanisms, as I have mentioned before, and also response to chemicals. We have the antibody-mediated and cell-mediated. And with this, we have up to 7 different types of hypersensitivity reactions. It's important to note that for the current lesson today, we will focus on cell-mediated. So basically, hypersensitivity reactions, especially to drug, the real-life classification, it's more based on latency and onset of symptoms and clinical picture than all these classifications of hypersensitivity mechanisms that we can find on the manuscript.
And in hypersensitivity, we distinguish between immediate hypersensitivity that ranges when symptoms occur below 1 hour to 6 hours, and we have delayed hypersensitivity when it ranges from more than 1 hour to days or weeks. And drug allergies, drug hypersensitivity reactions can occur in both of them. We have different phenotypes and also different endotypes. In immediate hypersensitivity, mostly we have a lot of mechanisms, including but not limited to IgE and complement and other receptors. And on delayed hypersensitivity, we have immunopathogenesis not completely fully understood today, and we have mostly T-cell mediated heterologous immunity and different involvements of other innate cells like NKs and cytotoxic lymphocytes.
So if we focus today on type 4 hypersensitivity reactions or delayed hypersensitivity drug hypersensitivity reactions, we have to mention that they occur in certain people and are often unpredictable, and this is very important on the matter of clinical diagnosis. The most common tissue involved is the skin, with maculopapular exanthema being the most common clinical manifestation of cutaneous delayed reactions. Nevertheless, these reactions can go beyond the skin, and we can have delayed drug sensitivity reactions causing severe cutaneous adverse reactions, what we call scars, well known as scars. They are rare, but actually very life-threatening with high morbidity and mortality. All scars are type 4 reaction cell-mediated with antigen exposure, in which an antigen exposes the drug activates the T cells, which then mediate all the tissue injury depending upon the type. The type of cell activation, the T cell subsets that are involved, and other effector cells that are recruited also from the innate immunity. We have the different types of cellular reaction.
Scars are still challenging ultimates, and among the most frequent and most clinically relevant scars, we will go through Stevens-Johnson syndrome and toxic epidermal necrolysis. We'll go through drug reaction with eosinophilia and systemic symptoms, generalized bullous fixed drug eruption, and also acute generalized examentomopsis pustulosis.
So, which is very important in terms of scars, is the early recognition of scars is paramount in preventing the potentially life-threatening sequela, and the variability of the clinical patterns still poses a significant diagnostic challenge in many cases. But what is crucial is the early drug withdrawal, and it's actually critical for the patient survival, the patient sequela, and the patient management itself. So if we see a brief overview of Stevens-Johnson syndrome, toxic epidermal necrolysis, it's around the incidence around 1 to 2 cases per million year, and the mortality ranges from 10% to 40% depending on the drug and the series reported. And it's characterized by a rapidly progressive, really acute, painful erythema, blistering, and epidermal detachment, often with cutaneous involvement. And it's a consequence of the extensive cell death of the keratinocytes, giving the appearance of a scalded skin. The diagnosis is clinical, and it's supported by skin biopsies and assessment of the surface of area involvement. The histology is it's a full thickness epidermal necrosis, and the most frequent sequelae are ocular damage, scarring, and psychological trauma. For the difference between Stevens-Johnson's and NET, it's a percentage of the area that it's affected. So basically, if we go to the immunological mechanism, we see here that there is the antigen presentation, and through the HLA and the peptide and the T cytotoxic, the drug-specific CD8 T cells accumulate within the epidermal blisters and release the perforin and the granzyme B that can kill all the keratinocytes, and this is causing all the epidermal detachment. And importantly, Stevens-Johnson and NET are primarily mediated by these type 1 cytotoxic lymphocytes, recognizing the drug antigens that are presented by the HLA, and these activated T cytotoxic cells, and the natural killer, also natural killer T cells are the ones that produce the cytotoxic proteins. For example, you have here granulosin, perforin, granzyme B, etc. But also, additionally, we have here T helper 1 cells around, and also type 1 innate lymphoid cells that and even macrophages and monocytes that release death ligands, very huge amounts of pro-inflammatory cytokines and alarmins. So all these collective action results in keratinocyte death, skin damage, and blistering in disease. So if we move forward, we find another very important clinical entity for scars, that it's stress, the drug reaction with eosinophilia and systemic symptoms that presents with a morbilliform rash, facial edema, fever, lymphadenopathy, eosinophilia, very importantly, and a multi-organ involvement that can go from liver, kidney, lung, or heart. Diagnosis is clinical and there are no validated diagnosis tests existing, but it's important to know that the scoring systems and multidisciplinary input are highly recommended. The incidence go from 1,000 to 10,000 depending on drug, and mortality ranges from 2 to 10%. The pathogenesis, the important hallmark is IL-5 and this eosinophilia that I mentioned before. In the histology, we have a lymphocytic infiltrate without eosinophils. It's very important also the viral reactivation. It's another characteristic hallmark of DRESS, and with cytomegalovirus or Epstein-Barr virus or herpes 6 or 7. It is characteristic also by the late onset, from 2 to 6 weeks after drug initiation usually, but also it may appear earlier if re-exposure. So this is an example of one of these scoring scales for criteria, diagnostic criteria of DRESS. This is the Registrar diagnostic criteria with several features on the latency, fever, skin involvement, the hematologic abnormalities, organ involvement, lymphadenopathy, and exclusion of other causes. You can see here that you have a positive or negative or zero score on each of these items for having a fever, yes, no, etc. And with this, you have a different scoring in which more than 6 points, it's definitely a DRESS. Also, for the there are baseline and complementary diagnostic workup for DRESS based on this. This is a report on 2024 on this Delphi consensus, in which is recommended for the organ workup is the hemogram, the renal and hepatic profile, and the electrocardiogram, and also the PCRs for the different more usually common barriers. And also then we have patients with a specific suspected organ damage or severe disease, and we have other options for selected patients only. Also, for DRESS, there is a proposed DRESS severity scoring or grading based on the Delphi consensus. We may have like a mild DRESS, moderate DRESS, or severe DRESS, and with this we have different organ involvement, but also you have to fulfill the different criteria, and with this you have different prognosis and patient management. Also, the acute phase management and the follow-up care depends on the classification or the severity of this stress. As a general recommendation, treatment is based on disease severity. Of course, the withdrawal of the culprit drug if it's identified, but corticosteroids should be initiated in all patients with confirmed death. But if it's mild, maybe you can have topical very high potency steroids, or for example, if you have a severe, maybe you have more systemic, and if you have also a refractory patient, refractory to steroids address, you may start also cyclosporine to be considered, and other biologicals that we can see further on. If we, for example, have a high serum load of cytomegalovirus, for example, we can start ganciclovir or valganciclovir, etc. Also, the timing of follow-up depends on on this grading, and we have during the first 6 months after onset, and then also as a follow-up we have consultations in which we also follow up steroid adverse effects and also autoimmunity disease. If we focus on the mechanism, immunological mechanism of address, we see that the affected skin is rich in CD4 positives and CD8 also T cells, and we find also Tregs and plasma dendritic cells and type 2 innate cells all together in the affected area, and the targ that it's secreted by the keratinocytes. And the dendritic cells are the ones that could recruit the type 2 helper cells to the skin and starting all the process. So through the antigen presentation, the drug-specific T cells are activated and produce Th2 associated cytokines that mostly as IL-4, IL-5, IL-13, but also increased levels of IL-33, the alarmins that are mostly secreted by keratinocytes and macrophages, are the ones that activate the innate immune system here, ILC2 via the receptors, and also it promotes the production of Th2 associated cytokines. Here in DRESS, IL-5, it's a crucial landmark, and eotexin-1 and TARC, they all synergistically promote the local accumulation of harmful eosinophils. And here we have also the involvement of the virus that we will define later. And if we move a step forward and we go for acute generalized exanthemosis pustulosis, this is the third type of scars that we are going through today. It's an acute febrile drug eruption characterized by numerous sterile pustules, mainly non-follicular, small, and in extensive areas of edematous erythema. It's also observed neutrophilia. The histology is on subcutaneous pustules and neutrophils, and we find it as 1 to 5 cases per million year and almost zero mortality. Antibiotics are the main cause, especially reported on beta-lactams, and also there is a scoring criteria for the diagnosis. In this case, Euroscar, similar as we have been describing for DRESS. There are several items to take into account, and with this we have several scores that give us as possible, probable, or definitive diagnosis. For generalized exanthematous pustulosis, it's very interesting to know that Th17 and axis that it's involved, Th17 cells and innate lymphoid cells type 3, different cells play a key role in producing all the IL-17 family cytokines, which induce the neutrophil recruitment and enhance also Th2 cytokine production, leading to inflammation. So, and it's interesting also that certain bacterial and fungal components can promote these Th17 responses. So these responses can result in tissue damage also via respiratory burst, enzyme release, and NET, and all the process of netosis. So in here, the innate immunity is directly involved, and we have a lot of AL8s also that is causing a neutrophil chemotaxis, and also very important, the axis of IL-36 and IL-17, IL-22 involvement. It's remarkable. And in here, we will see later on that we have developments of novel biologics for refractory cases. And finally, we'll focus on generalized bullous fixed drug eruption. It's a severe variant of the fixed drug eruption characterized by widespread bullous lesions, and they characterize that because they are well demarcated erythematous or alveolar patches with flaccid bullae, blisters actually, and they have recurrence patterns at same site. It's they repeat in the exactly same sites where they have occurred previously, and it's a rapid onset as well, but usually with hours to a few days after drug exposure. It's generalized, but it's not important to know that but still there are interspersed areas of normal skin that remains intact, and we see in generalized bullous fixed drug eruption less mucosal involvement that Steven Johnson net, and mortality ranges from 11 to 22%, and the common drugs involved that have been reported are NSAIDs with ibuprofen and diclofenac as important ones, but also paracetamol and antibiotics. In generalized bullous fixed drug eruption, we have a lot of mediated, they are usually mediated by memory T cells and central memory T cells, and the resident memory T cells are the one that are recognizing and participating in the antigen presentation, and they secrete cytotoxic proteins, the granulosin and perforin, granzyme B, but also cytokines of interferon gamma and TNF alpha here, which are causing the damage. So actually, it's important to know that multiple factors influence scars. We have the drug antigen presentation with different theories that we will see further on. Also, we have genetic polymorphisms in HLA or drug metabolism enzymes that have also been reported, like the CYPs, that have also been reported important in certain scars induced by drugs, and also we have different immune and cell death mechanisms involved, not only from both innate and adaptive immunity. We have Th1, Th2, Th17. We have a lot of cell death signalings and cytotoxic proteins, but also importantly, there are environmental or non-genetic factors like the virus infections and the impaired drug metabolisms in certain patients that are also influencing the occurrence of scars. Very recently, it has been reported by Pichler that the type of drug hypersensitivity is function of a drug affinity, precursor frequency, and also the HLA allele. So in here you can see time and different scars, and you see how if there is a low to moderate affinity to a multiple HLA, mainly T cells activities, it's quick transient stimulation, we have the maculopapular exanthema. But when we move to scars, we have different situations. In dress, we have a lot of cells and lymphocytosis. We have very high affinity and few precursor T cells and a long cell expansion period. That's maybe why it appears lately. And with Steven Johnson's, we have lymphopenia, high affinity, but we have here few precursors of the T cells, and the cell expansion goes to exhaustion. So it's different situations for each clinical picture. So when a drug is, we have different proposed models for the immunological recognition of the drug. So in here we can see that the antigen presenting cell presents successfully a peptide A on its HLA, which can bind specifically to the TCR of T cells, which is not for the peptide B, right? So when a drug is added, we face three models as possible based on this interaction, depending on the type of the drug. So we have the apten-proapten model, in which the drug binds to the endogenous peptide. This is peptide A from the previous, and with this they go together. They add together to the TCR. There is also the PI model, in which there is no non-covalent binding, in which the drug can bind directly to the TCR in dark blue, or actually to the HLA. No, but not to the drug. This is the difference. And also there is another third possibility that the drug is causing an altered peptide repertoire model. So the drug binds to the binding pocket of the HLA, modifying the affinity of this peptide A. And it kind of turns it into the peptide B. So it changes really the situation of the binding. Also, it's very interesting, and with the use of checkpoints inhibitors, we are facing that there might be a drug antigen independent activation with the T cell overactivation with these interactions. So additional mechanisms, including the form of the drug being metabolized or not, and this would be influenced by the genetic factors. Also other factors like the peptide loading process, depending on or not on the tapacin, in which we have a change on the affinity of the peptide, and also HLA predisposition and the TCR clonotypes and the expansion of certain clonotypes. It's also influencing the pathogenic mechanism beyond the drug recognition itself, and this is extremely important. So, as you know, HLA is considered a susceptibility risk factor in some drugs, and some of them have been really defined. For example, HLA B1502 for carbamazepine in Steven Johnson, or B58.01 for allopurinol scars, etc., etc. But this is very important that we have to know that it really depends on the ethnics and the situation of the patient, and where it's coming from, and where is he living, etc. So with this, the risk of an HLA association has to be considered. And also very important and very interesting, we have the hypothesis of the danger signal hypothesis, in which cellular damage also induces the production of danger signals that activate the antigen-presenting cells. So in here, all this, the drug is causing this cell damage, and the cell damage, and it's creating danger signals that are activating dendritic cells on TLRs, and this is a very powerful. Also, pathogens that activate TLRs on dendritic cells, and we have an important activations of antigen-presenting cells that are favoring the drug recognition. So the drugs themselves, or concomitant substances from viral infections, are the ones that can induce danger signals, and therefore initiate all the loop of the allergic reaction leading to scars. And it's very important that viral reactivation is another characteristic hallmark of scars, and very especially in dress, right? Scars, it's not clear what's going on here. So scars may be the cause of virus reactivation. We have it depicted in A, which is some way the main hypothesis to go from scars to virus reactivation, either by the upregulation of immune receptors from the virus, entry and replication. This is the left panel, or by promoting the activation of Tregs. That these Tregs at the end lead to immunosuppressive environment, and this allows to have a virus-friendly environment in here. But also there is the alternative hypothesis that is coming from the virus reactivation to scars, because a lot of these scars appear in the context of a viral infection already, and it's a reaction to the drug. So virus infection with or without a associated drug prescription might promote the scars actually, and by influence either the production or proliferation of scars, immune cells and mediator, or by a cross reaction of antiviral specific memory T cells and to HLA. It's like a drug similar to HLA virus, right? With the right panel. And here we have a lot of questions mark because they are more kind of theoretical mechanisms that could be happening, and they are not fully demonstrated. But yes, in viral infections are important in all the process, and maybe in all the pathogenesis of scars and stress. So which is the aim? The aim is to identify the culprit drug, because with this we have the relevant, the endotype, the mechanism, and which is the relevance of phenotyping the immediate drug hypersensitivity reaction. So we go for precise diagnostic, avoid false labeled patients, and also causing harms in patients with reactions. So and with this, also with this precise diagnosis, we have patient management and therapeutical interventions. We may have the sensitization procedures applications, accuracy of drug avoidance and recommendations, future alternative drugs recommendations, and understanding the understanding roles of comorbidities. And for this, the clinical history is fundamental for the etiological diagnosis. We have to take into account deep account elementary injury, the distribution, whether there is mucous involvement or not, the systemic symptoms, and also the calendar, the drug, whether the response to withdrawal, the response to resumption, on all the delay on the onset, early onset, etc. And then we'll take into account the complementary test results that can be either in vivo or in vitro. What a complementary test. So we have, for diagnosis, we can go from oral challenge, Cutaneous test, intradermal test, T-cell test, prick test. But if we are strict, oral challenge and intradermal tests are contraindicated, and for prick test, there is no huge evidence. So after all, we go for epicutaneous test and T-cell test. There is not a perfect one of which that fits all, but epicutaneous tests are considered safe. There are very rare reactions reported with epicutaneous tests, although they exist, of course. The positivity ranges from 18 to 75, depending on the drug and the series reported. And some of the issues is that it's not clear the concentration or the vehicle for all the drugs. Regarding T-cell test, it's true that the sensitivity is quite low. It really depends on the drug and the framework in which we are between, and the time lapse between the reaction and the test. But it's also true that the specificity is really, really high. So actually, for the diagnosis workflow, for even that delayed hypersensitivity reaction, drug hypersensitivity reactions can cause life-threatening conditions. In vivo tests, like skin tests as well as drug provocation tests, have to be really cautiously performed by drug allergists, dermatologists, whoever, and have not been recommended actually. So that's why the accurate recommendations today it's to use in vitro test, if available, of course, to be performed prior to any in vivo test. It's to avoid or minimize the provocation risks. It's true that they are still challenging to identify the culprit drug for delayed hypersensitivity reactions, and they have a lot of drawbacks, the in vitro test, but it's a safer alternative. So what can we do actually in vitro? So most likely we can do very little of what it's actually going on the real pathways and mechanisms of cells and mediators. So this is an overview of the current situation. You know, we have been talking that this is a simplistic situation of depicting T cells, and it's focusing on type 1 cells. But we know that we have Th17, the cytotoxic cells. It just depends. But we can in vitro, what we can do is to induce a proliferation of the T cell clones that are drug specific, and to see whether this proliferation is occurring or not, to check for the mediator release and cytokines, etc. In terms of in vivo testing, what we can do is epidermal test and intradermal test. Patch test, sorry, in which we exposure the patient with the drug, and we wait to observe the reaction occurring on the screen. So, what about lymphocyte transformation test? We see that still it's very it's highly specific, but the sensitivity can be really improved for some drugs. And in here we have antigen presenting cells from whole blood. We obtain PBMCs, and with this we exposure the PBMCs for cell culture from 5 to 7 to 10 days, depending on the protocol, and in which in here we have the specific clone recognition and the proliferation of drug-specific T cell clones. And we see the former assays are still now for research areas. We thymidine radioactivity is used for the readout, but also by flow cytometry with CFSE green dye, you can also observe the proliferation of these clone-specific codes. And we'll see further in detail some modification of this protocol, and also adding the cytokines detection in the supernatant is really can be really improving the test outcome and the readout. You can see here that for some tests,
It's very important to know that the reliability of the test depends on sensitivity and specificity. So theoretically, lymphocyte transformation test seems to be useful in all types of the delayed hypersensitivity reactions. However, when the sensitivity of the test is evaluated in different series, it's actually it ranges to 17 to 100, as summarized in several papers and in the literature. So this is important to take into account. And also, this sensitivity specificity depends on the clinical phenotype and also the drug that is involved.
Drug itself. Why? And the question is why they are not. We see that they are not really sensitive, or we could improve in sensitivity. It's because maybe the question is that why current in vitro studies have so many limitations. First, because do we have sufficient detail of the mechanism that we can really reproduce our possible mechanisms in vitro in the T cells, or that this also applies for immediate cells wherever, and which is the impact of time. If we have a T cell reaction, and we have a T cell clone expansion, and these specific T cells go to the memory compartment as if we were having an infection, it's like a simulation of what could happen. If we test the patient for looking for effector cells when they are already maybe on the T cell memory compartment, we will have a less sensitive test. Also, it's very important to know the influence of immunosuppressants and immunomodulations and on the immunological response. So, how is this affecting our test outcome? And also, are we really capable of reproducing in vitro what is the influence of the infectious context, the danger signal therapy, and the danger theory, or on the development of the reaction? So about sensitivity and specificity, it's the same with the intradermal and the patch test. It's equivalent to the lymphocyte transformation test. Well, not all patients with clearly positive skin tests also have a positive lymphocyte transformation test, and nevertheless, it has been revealed that the in vitro test is superior to skin testing for some reactions. So the sensitivity can really differ. For example, so it's not the same, and in here you can see from Cabanas, and they reported in 2018 that with sensitivity of the lymphocyte transformation test was at almost up to 60 versus 30 in patch in tested in patients tested with beta lactams, NSAIDs, and some antiepileptics. So the immune response, if observed in vitro, may differ from the in vivo situation to the elimination, the formation of the presentation of the drug protein conjugates in vivo, etc. So it's important to have in mind these possible discrepancies between tests. Okay, so
So, conventional in vitro lymphocyte transformation test for diagnosing drug hypersensitivity reactions is limited by the low sensitivity, as we have seen before. So, to improve the detection and assess T cell activation strength, it has been recently published an adaptation of the test with a cytokine-based assay in which they measure the cytokine secretion in the supernatant after 7 days of culture. So, it has been proved that with type 1 interferon gamma, IL-5, IL-13, and cytotoxic mediators detection, granzyme B and granulocyte, we can better characterize and phenotype the different scars that can be occurred. And it's very interesting that also it has been able to report a grading system defined by strong responses as cytokine stimulation indices. And for the first time, we see that cytokine responses increase dose dependently, and actually with more severe reactions like DRESS, the intensity is even higher. So this is like really promising an improvement on the use of in vitro test for identifying not only the drug but also the culprit drug, but also quantifying the immune activation strength and the implications that this may have for informing risk assessment, and particularly in guiding caution with related compounds and patient risk for a severe or recurrent reaction.
so actually, this including the cytokines in a test is very important, but possibly it's time for something new. So with the application of the innovative techniques, we have all the omics to improve the performance of the in vitro studies, and with this also indeed we need to obtain cells from the blood and PBMCs from the patients. We have antigen presenting cells, we have lymphocytes, helper and cytotoxic, and we have the drug. And with this antigen and with this reproducing this with this the immune reaction and testing for all the different subsets and T cell populations and in innate lymphocytes, we can analyzing the cytokines in terms of transcriptomics, proteomics, and metabolomics may really be more informative on what is going on, and we have the chance to integrate these innovative methods to improve the in vitro diagnosis and to have real biomarkers to really understand the basic mechanisms of this drug allergy. And since it has the roots on the activation and expansion of the drug-specific T cells, the detection of these corresponding molecular changes of the immune cells can really be promising. Okay, so also maybe we can sort apply cell sorting techniques in being able to compare by flow cytometry, cell separation, the behavior of each of these groups, analyze molecular changes in the specific immune cells, in how cell activation is induced, proliferation, etc. So we can have the gene expression analysis and quantitative information, transcriptomics, etc. So we are facing probably an opportunity to have novel biomarkers to be able to develop novel tests, in vitro tests, but also novel targets for therapeutics. So if we move to management, as a management overview of the patient, of course, most important is the immediate withdrawal of the culprit drug. That's very important, but also the supportive care, the ICU unit, for example, in the Steven Johnson's and 10, and also fluid electrolyte balance, pain control, and multidisciplinary mucosal care. And also, especially if there's another infection prevention and the treatment of all the disease. Okay, but we know that for this we need the immune response is so powerful that we need immunomodulatory therapies. So we have conventional, but very interestingly also we have emerging ones. So conventional therapies, we have the systemic corticosteroids, although controversial in some aspects, but we have cyclosporine inefficacy. It has been reported as effective in some reports in Steven Johnson and Andres, but also immunoglobulins, intravenous immunoglobulins. But what's emerging? What's going? What's new? We have anti-TNFs, basically mostly etanercept that is being used, and interestingly we have the JAK inhibitors, tofacitinib in DRESS, and we have anti-L5, mepolizumab, and anti-L17 and anti-L36 in AJEP. So the emerging therapies. Overall, biologics anti-TNF-alpha inhibitors, etanercept, anti-L5 agents, anti-L17, anti-L36, and all these targeted small molecules represent the most active area of innovation, with ongoing research and safety in scars. These agents are not yet not yet a standard of care, but maybe considered in select steroid refractory patients in which we don't get the appropriate. So we can see here we have etanercept, and which is the one that has been more frequently used, and infliximab, and in here we have other options, and here also the JAK inhibitors. It's promising, although the accumulated evidence is relatively poor. It's an option for refractory in the patients with refractory disease scars, refractory to steroids.
So regarding emerging therapies, it's very important to know that we have biologics and JAK inhibitors that are intended to control, to block all these cytokine and inflammatory mediators. So type 1 and type 2 cytokine receptors comprise of units that physically associate to Cutaneous, given that because these receptors, they don't have any enzymatic activity that let us transduce the intracellular segments, so they benefit from the participation with JAK. Actually, what we have here is that monoclonal antibodies are the ones that can block type 1 and type 2 cytokines and their receptors in different manners, just trapping the cytokine or maybe interacting with the receptors. But by contrast, we can see here the biologicals interacting with the drug. with the cytokine, sorry. But by contrast, JAK-inhibitors, what they do is that they block cytokine signaling by inhibiting this kinase activity, thereby preventing JAKs from phosphorylating stats and other substrates, so that intracellular signals cannot be transduced. And with this, we dampen the inflammatory and damaging response. And it's important to know that next generations of JAK inhibitors are thinking of on the effects of targeting different JAKs. So different receptors associated with different JAKs, so that selective blockade of one JAK can inhibit a specific biologic function, while allowing other JAK-dependent cytokines to signal normally. And this is very important in terms of side effects and the patient management. So this is something that has to be considered, and with new development of new drugs and the use of these potential emerging therapies.
So, which are the take-home messages? There's a clinical diagnosis. Clinical history is crucial. The pathophysiological mechanisms of the hypersensitivity are today more complex than those that have been described classically, and have led to the need of a new nomenclature and a new interpretation of pathology. And in vitro models also that are currently available are still limited, and they respond to all this to respond to all this variability and complexity of the underlying disease. And the lymphocyte transformation test is useful in vitro for the identification of the culprit type. Despite the sensitivity, it's not optimal, and but the specificity is high and it really depends on according to the drug and the clinical phenotype. So what's been reported is that complementing it with the detection of cytokines can improve the performance of the test. And actually, the factors like such as the time between the reaction and the test, and all the immunosuppressants at the intake, not only steroids but other concomitant immunosuppressants or immunomodulators can affect the test outcome. And the incorporation of omics opens new perspectives for the field, especially in understanding the mechanisms underlying the reaction that may lead to the development of novel therapies, but also to identifying diagnostic biomarkers that are much required. Emerging therapies with biologics and targeted small molecules represent the most active area of the innovation, with ongoing research into the efficacy and safety in scars, although not yet a standard of care, but may be considered in select steroid refractory patients. And that's all. Thank you very much for attention, and I'll be happy to give answer to your questions. Thank you.